So my name is Ian Suchu Lam. I'm a PA at UHN, and today we're going to be talking about the larynx and some of its anatomy and an approach to grossing. You should all see a picture of some larynxes up on the stream. Okay, great. So let's start off with some general larynx anatomy. So we're going to do this in the style of Dora the Explorer. So when I point out a structure, I want you to scream the answer into your computer or type it into the chat. So let's start with the image on the left, which is an anterior view of a larynx with a question mark structure at the top. So type your answer into the chat box for what you think this structure should be. Hyoid, yep, hyoid bone, yes, exactly. And just below that in red is the this structure in red. So this is the thyroid cartilage. Yep. And just below that is the cricoid cartilage in yellow. Sorry, I didn't give you a chance to answer that one. But the cricoid cartilage is important because it's actually a complete ring of cartilage, unlike the thyroid cartilage, and that'll help us differentiate the two when it comes to grossing. So moving on to our diagram on the right, which is a posterior view of the larynx. Right above the cricoid cartilage in blue is, and type in your answer, this blue triangular cartilage. So this is the arytenoid cartilage. And above that in purple, this cartilage here is the cuneiform cartilage. And then finally, our structure in green right here. It's quite large. Prevents us from choking on our food sometimes. Yep, is the epiglottis. Great. So in practice, this is what our specimen should look like from the posterior aspect. There are two new things that we have labeled here. So let's start with this structure on the superior aspect. Again, type in your answer into the chat. It connects the epiglottis to the arytenoid cartilage, so it is the aryepiglottic fold. And just down here, between the thyroid cartilage and the cricoid cartilage, as an extension of the hypopharyngeal mucosa, is this structure down here. This is also going to be one of our margins. Any answers for this structure here? Yep. So Prashant said piriform fossa, and piriform sinus is our answer, so that's correct. Moving on to some final structures, we have an opened posterior view of the larynx. So let's start by going over some of these central structures. This first superior fold is known as the false vocal fold, and the fold beneath it the inferior fold. Yep, the true vocal fold, and in between them, the space between the two vocal folds is this is known as the ventricle. And then we also split up our larynx into 3 different regions. The first, from the tip of the epiglottis down to the ventricle, is called the supraglottic region. And the area between the ventricle down to around 1 centimeter inferior to the true vocal fold is called the glottic region, and the area from there down to the inferior border of the cricoid cartilage is called the infraglottic area. So Prashant definitely leading the charge there, letting us know that this is indeed the supraglottic, glottic, and infraglottic region of the larynx. So now we're going to show you a quick video on a specimen that we received a while ago. Hopefully the audio works, but please let me know if you can't hear anything. This is a total laryngectomy specimen that was taken out for a necrotic lesion. The specimen has already been fixed with its margin inked black. We're just going to go over the general anatomy of the larynx and a few things that we need to consider for laryngeal cancer cases. So just to get oriented, this is an anterior view of the larynx with our superior aspect here and our inferior aspect here. We can immediately identify a couple of structures, including the epiglottis, hyoid bone, and some anterior skin with a central defect. Normally we would expect that this area represents a tracheostomy site, but there are a few reasons why this is probably our necrotic lesion instead. It should become apparent as we go through the rest of the specimen. Now we're flipping our specimen over to the posterior aspect, where we can get a better look at our laryngeal mucosa, our airy epiglottic folds, and our piriform sinus, which also appears to have a defect in it. It's standard protocol for us to open the larynx through the posterior aspect, cutting through the trachea and cricoid cartilage in the process. This normally lets you visualize the vocal folds, with the superior vocal fold being the false vocal fold and the inferior fold being the true vocal fold. The space in between is called the ventricle, and the anterior and posterior commissures connect the left and right halves of each vocal fold. The supraglottic larynx is considered to be the area between the tip of the epiglottis and the ventricle. The glottis continues from the ventricle down to about 0.5 to 1.0 centimeters inferior to the true vocal fold. And from there, the subglottic larynx is considered to be the area from there down to the inferior aspect of the cricoid cartilage. So from this view, it's clear that this is actually our necrotic lesion and not a tracheostomy site because it's way too far up. This is our trach site, which is right where it's supposed to be within the trachea. Another anatomic structure we need to think about is the thyroid cartilage, which is found immediately superior to the cricoid cartilage on the anterior aspect of the specimen. The thyroid was also taken out with this specimen, and it'll be found inferior to the thyroid cartilage in this region. So if the necrotic lesion is a tumor, we're definitely going to have to think about margins. So for this specimen, we'll have to consider our airy epiglottic fold margins, our piriform sinus margins, our posterior cricoid mucosal margin, inferior tracheal margin, left and right soft tissue margins, pre-epiglottic space margin, which is this fat-filled area in front of the epiglottis, and our skin margins. Once we take our margins and suction through the tumor, we should be able to get a better idea of the extent of invasion of the tumor, which is critical in our tumor description. We need to describe whether the tumor is supraglottic, glottic, or subglottic, whether it crosses the midline, and whether it involves any of the structures we previously mentioned. It's also very important that we document any tumor extension into the thyroid cartilage, strap muscles, tongue, thyroid, or esophagus. So at this point, we would say that our lesion is transglottic, crosses the midline, and erodes through the thyroid cartilage. Okay, all right. Thanks for joining us, Dr. Smith.
Yeah, no problem. Thank you for having me.
Yeah. So we have a couple of questions about the larynx here. Um, so, what are some of the most important things to be aware of when grossing a laryngectomy specimen, in your opinion?
Yes, so the larynx is all about. Hold on a second. Let me move there. I'm getting a lot. I'm getting like my own voice echoing in the background. So I'm going to take off the headset here and just
Sure.
talking to the microphone for a while.
Yeah.
The most important thing by far about larynx is it's a lot like I always tell the residents that it's similar to an autopsy in the sense that if you don't get it from the gross, you're not going to get it. You're not going to get your final diagnosis or anything that's happening after that.
Right. So, definitely no pressure on the grosser, right?
Yeah, yeah. It's unfortunately it yeah, yeah. Unfortunately it's wow. There's
It sounds like there are some technical difficulties, but I'm just glad that uh, we can actually hear you. Just let me know when you're back.
okay. Yes, can you hear me now?
Yeah, I can.
Okay, great. Okay, let me continue my thought for a second there.
Yep, go
So,
ahead.
um, the bulk of everything is on the gross and the larynx, particularly if you look at the CAP criteria. The majority of the T staging, the overwhelming majority of the T staging, just relies on both the clinical impression, the radiographic impression, as well as the gross findings. My job at the microscope is essentially to confirm gross findings and um, document whether it truly is tumor that's extending into a given area or whether it's just some kind of a fibroblastic response. Does it actually, it appears to be transglottic, but does it actually go up into the supraglottis or down into the subglottis? Or how does it, um, do, are different structures involved? Or is the cricoid truly involved? Is the hyoid bone involved? Things like that. And so each of those can have different meanings in terms of aggressiveness. But from the bulk of it, of course, comes from the sampling. I can get lost very easily at the microscope if I don't understand where the tumor is going, and so the understanding the anatomy is very, very important. And documenting what structures are involved. It's a lot like a checklist. So it does it cross the midline? Is the left set of vocal cords involved or the right set involved? Is it coming down into the thyroid cartilage? If so, is it doing so on the left? Is it doing it on the right? On both? Bilateral? Is it including the anterior commissure, the posterior commissure? How about and the most common thing that people forget to comment on is the tracheal, the skin, or the stoma. I need to know what the proximity of the tumor is to that structure, and also does that appear to be involved. And you do have skin there as well, so sometimes I get a little bonus mole. I have found a melanoma once, incidentally, in skin that was taken off as a mole, turned out to be melanoma. And so these are kind of important things that you have to document as we go along.
Right. So sectioning, sampling correctly, and knowing all the anatomy and knowing which structures are important is pretty critical to sign out, as with any specimen.
Oh yes,
Okay.
absolutely.
If you could choose one section, what would you say is the most critical?
Yeah, it's it, so it depends on where the tumor is located.
Right.
Generally speaking, any section that would give me the depth of the tumor in perpendicular to the mucosal surface. That's probably the most critical section because then I can see most of the overwhelming majority of these are squamous cell carcinomas arising from the surface epithelium. If they're diving, I need to see how deep they're diving into the surrounding soft tissue, into the adjacent structures. Um, yeah, probably. Yeah, that's probably the most critical section that I see.
Okay. So if we only had one block printed, for instance, that's the one that we would go for.
Yes, absolutely.
Okay. So can you tell the difference histologically between the true and false vocal folds?
So theoretically, you can, because the true vocal cords have vocalis muscle and vocalis ligaments. So in a perfectly normal larynx at autopsy, or sometimes we get T1 disease and you get normal sections of vocal cords, or even if it's just an epiglottic tumor, that kind of a thing. Theoretically, you can tell the difference. Um, Unfortunately, when it's a glottic tumor, or most of the time when these larynxes come out, it's already involving this set of vocal cords, and half the architecture is obliterated. And you got to remember that up until the false vocal cord, it's a respiratory pseudostratified respiratory epithelium that's coming down. And once you hit the down into the ventricle and coming around toward the true vocal cord, we turn into more of a squamous mucosa. But then once we come back down to the larynx or the trachea, down toward the trachea, into the infraglottic region, it becomes again respiratory type mucosa. So if you take a perpendicular section through that false vocal cord, ventricle, true vocal cord, I essentially get a sandwich that is pseudostratified, then squamous, then pseudostratified again, and I get lost very easily. And without the vocalis muscle, I wouldn't necessarily be able to see it. Even if I do see vocalis, I'm not 100% sure half the time that it is vocalis muscle.
So in theory, you could, but in practice, probably not so much.
Yes,
Okay. So
yes,
you mostly rely on the gross to determine whether a tumor is supraglottic versus glottic versus infraglottic.
yes.
Okay. And I'm assuming that pictures are very helpful here.
Yeah. So I pictures are always helpful in head and neck, particularly in these um, very complex specimens, maxillectomies. It's the same story, or half, hemifacectomies, mandibles. Any time it's a complex specimen in the head and neck that's essentially not part of a tongue, that's coming off partial gloss. It really does help to have photographs of that. The classic view of a larynx is opened up along the posterior side, just as you were showing a second ago, and it was um, and just being able to see where that tumor is, and being able, to correlate what I'm seeing with, or what you're seeing grossly with the radiography. And then the other thing I correlate with is the laryngoscope report. So at minimum, every one of these patients has one uh, laryngoscopy done at least a good 2 or 3 weeks before surgery, and then they almost always have one done or immediately pre-op. And so right before the resection starts, they'll throw a scope down just to confirm where the tumor is and to see how large it's grown, things like that. I do try and take into account what they're seeing grossly, or what they're seeing via the endoscope, and what you guys are seeing, and try and reconcile where the tumor is. It's much easier to do that if there's a photograph.
All right. So photographs definitely important with head and neck specimens, and um, definitely critical in your ability to correlate what they're seeing clinically and what we're seeing grossly,
Yes.
and histologically. So does that endoscopy information factor into the staging criteria? Because I noticed that, for instance, sometimes you have to characterize whether there's normal vocal cord mobility versus vocal cord fixation in differentiating some of those stages. For example, glottis PT1 versus PT2. Is that endoscopic information used for that?
Yes. So, the head and neck is kind of the larynx criterion, and there's one more. I think the thyroid is the other one. Um, they're somewhat odd in that it requires clinical information to fill out the pathologic staging and report. It's just an oddity of these CAP protocols. But yeah, so I do require, or I have to rely on the clinical information and the endoscopic report to tell me whether or not those vocal cords are fixed or not. If it's clearly a glottic tumor, and I can, and you're that it's pretty evident whether or not the thing is fixed, whether there's mobility on one side or not. But sometimes it's much more difficult if it's if it's supraglottic tumor, but you're wondering if there's submucosal spread that could, or infraglottic in the same thing if it's spreading upwards. Um, that can become very challenging in terms of just looking at a photo and being able to tell. The other question is whether it's, again, if it's across the midline and you're wondering is the opposite side affected. But for PT2, PT3 lesion staging in T3s automatically, if it's fixation, sorry, let me say this the other way around. If there's vocal cord fixation, it'll automatically get you to a PT3, and regardless of where your site is. And so, if that's usually one of the first things I start looking for in the laryngoscopic reports, either in the operative note or in the one that they've done 2 or 3 weeks earlier. If I can document fixation, then I'm automatically at T3, and I can immediately stop sweating whether we're, um, where we are and what structures are involved. The only thing I'm looking for at this point is just advanced disease to get me up to T4.
That's actually very fascinating and probably a really good takeaway point for our residents. Just a quick path to a higher stage, because it gets pretty messy in the lower T stages for each of these tumors. Do you have any other tips or tricks to approaching staging of these cancers? Because between the T stage and the end stage, there's a lot of information to sift through. And I'm sure I'm not the only one who feels overwhelmed when trying to figure out what sorts of information is important for us to include in the gross in order to help ease the process of staging these tumors.
Sure. So, unfortunately, for the T stage, let me just lead off with the word unfortunately. I don't know how much help I'm going to necessarily be. The T3 trick is the one that I remember most of the time. Usually, when larynxes come out, the typical story is that it's an advanced disease to the point where the vocal cords are already immobile or impaired significantly. That's the typical story, and the reason for that is because you typically don't do a full laryngectomy for T1 disease. You can go in, you can do a micro, what's termed as a just a microscopic excision or a microlaryngectomy, if you will, and they'll just go in and just sort of piecemeal take off the mucosa. It's a very superficial endoscopic resection. That's quite possible to do. I don't really care for those myself because they're very difficult. They're usually incredibly cauterized and very difficult to interpret and to sign out. But it does preserve vocal. It does preserve the larynx and preserves the voice. By the time we actually get a larynx, usually the tumor has grown to the point where the vocal cords are already uh, gone. So it's unusual to sign out a T1 or T2 larynx. Now, that being said, the thing that will automatically get you to a T1 is if you're obstructing the airway, of course. We had, I think a week or two ago, the resident service I had a T1 larynx, which was the first in a while that I've had for that, because it's just a gigantic glottic tumor, but and it's papillary, rather pedunculated. So just hanging off of, I think it was the false vocal cord probably, but large enough to obstruct the airway, it required essentially an emergent laryngectomy. Um, so you will kind of see that. For some reason, they couldn't go in and just remove it endoscopically. Um, the other thing that they'll do for T1 and 2 disease is they'll laser sometimes, just to take, especially if it's dysplasia, you just laser over it. That's the other option. So it's unusual. Most of the time when I get a larynx, it's either T3 or higher. And then as far as trying to figure, I have to look up every time. I'll be quite honest, I have to look it up every time because I don't see them frequently enough, and I can't remember which category, because supraglottis, infraglottis, and glottis are different. I can't remember which structures are involved in which, uh, depending where it is. As a
Right.
general rule, the deeper it goes, the higher the stage. And once it involves either the prevertebral space or the carotid artery, or if it extends into the mediastinum, that's a 4B automatically on every level. If it Beyond that, though, it's really T3 to T4A. There's not really a great way. I have to look it up every time.
Right.
Now, switching from T stage to end stage. So the end stage for larynx is much. Um, it's the same end stage that you use for all other head and neck cancers that are P16 negative. So the only exception to this would be a P16 positive oropharyngeal cancer, which has a different end stage. But otherwise, this end stage, if you just it's bulky, and it's got a lot of exceptions and a lot of it's not exactly the most well written of end stages, but it at least applies to multiple synoptic reports. So it's one of those things that if you just sort of memorize it, and if you do these or sign them out enough and memorize them more, then at least it'll come in handy in multiple things. From a grossing perspective, they're usually just lymph node dissections. Half the time they'll come out separately, is my observation. It depends who the surgeon is. Sometimes they'll come out separately as dissection. Sometimes they'll come out with the larynx. If you can, when they come out with the larynx, if they come out with any kind of, on rare occasion, they'll come out with sternocleidomastoid, or they might even go high enough up to get a little bit of submendiv. I've seen that once. If you can orient and approximate the levels, that's great. But no one's expecting perfection. None of us are expecting perfection when they take them out like that end block. That being said, really the question is, for uh, lymph node staging, the numbers to remember are 3 centimeters and 6 centimeters. If you're going to sample a lymph node, it's helpful if you tell me the size of. You guys always give me a range. That's very helpful. If you just tell me representative sections of largest lymph node, because clearly it's positive. I can see that it's positive. I just need to know whether it is. The other thing is, try my advice is 1 section per centimeter of lymph node, especially if it's 3 to 6 somewhere, or a larger type lymph node. And the reason for that is, as you might have noticed, the new protocols require evaluation for extranodal extension.
Right.
And in an effort to try and give um, that its due justice as best I can, or due diligence, that's the word I should use. I think appropriate sampling of the lymph node capsule, if such a thing can be identified, is necessary. So if you do 1 per centimeter, and you're not giving me the middle of the thing, I don't really need that, because I can see that it's tumor. I'm just more interested in kind of the interface between the outside, or the sort of capsular type area. Half the time in the head and neck, these are matted lymph nodes, so it's automatically E&E, and it's not going to matter. Once you have E&E, you're automatically a stage 2A. Uh, yes, you're automatically a stage 2A once you have E&E, that's correct. And if you have more than 1 lymph node, or, well, No, sorry. If you're larger than 6 centimeters, you're automatically in three. Those are the two things I sort of remember as general rules. If you cross the midline, I think you automatically go up to an N2 as well, N2Cs, if memory serves. Um, and so that's, oh, it's actually right here in front of us. I'm reading it. So these are just kind of the uh, useful little tricks I try to remember. Um, Again, every single case, I have this thing plastered next to my microscope, and
Right.
I double check every case because the worst thing I can do is stage it incorrectly.
Hmm.
Um, from a grossing perspective, generally I don't have issues with lymph node dissections. Most of the time, it's pretty straightforward.
That's a relief to hear. So if you have a tumor that crosses the midline, how do you handle ipsilateral versus contralateral lymph nodes? If it's on both sides of the larynx, would all lymph nodes just be ipsilateral? Does that question make sense?
Would all there's like a delay in the, okay, there we go. So if the tumor crosses the midline within the larynx, so most of the time the ENT will be able to observe that on the laryngoscope. So that'll sort of direct whether they're going to do um, bilateral dissection or not. If they don't do that, I do, it is still very helpful. That's an excellent point. I'm glad you brought that up. It is still very helpful to separate left and right lymph nodes if you identify them by chance. If most of the time, if the tumor's in the left, they're going to do a left dissection. If they're going to do a dissection at all, they might leave the right alone. It just depends how big the tumor is and whether they think it's crossing the midline or not. Um, if you but it is still helpful if you guys can differentiate that. Very helpful.
And one final point on lymph nodes. Is this talking about deposits? So size of metastatic deposit is 3 centimeters smaller versus the lymph node as a whole. So say, for example, you have a 1 centimeter tumor deposit in a 3.1 centimeter node. Would that be counted as a 3.1 centimeter positive lymph node, or are you just counting the deposit?
No, that's right. It is the just the deposit size is what really triggers, which is kind of funny because when we did the original data, when the paper came out that actually influenced how CAP is done, the data is based on the lymph node size, not on the deposit size. But somehow in all of the discussions, it got watered
Right.
down to being the deposit size. And I think some of that came out of the thyroid literature,
Hmm.
which influenced this group in, unduly in part. And so, anyway, as a result of all of that, we do use the deposit size.
Okay. All right. So maybe some of that got a little lost in translation.
Yeah.
But okay, that's interesting to hear. So, what's the clinical impact of a positive margin? And does that differ from a close margin?
Yeah, that's a great question. So, at frozen section, most of the time, any margins are going to be dealt with at frozen section. And if it's positive at frozen, depending how much room surgeon has to go back, they'll go back and try and give you a new margin as best they can. So there's a couple of scenarios to kind of think about here in general. First would be negative margins, and I mean widely negative. So at least 3 millimeters, probably 5 millimeters. Sometimes you can get a full centimeter away on, especially in larynx specimens where there's a lot of bulk in the neck and a lot of fatty tissue that you can kind of get as a cuff. You can use the thyroid as a barrier, also to kind of give you a margin as well. Um, and so if you have widely negative, then we're done. And generally, the patient wouldn't necessarily even need follow-up radiation therapy. Um, if we have a close margin and it's coming within a couple of millimeters, that'll probably go to a tumor board most of the time. And most of the time, the tumor board will probably say, yeah, you need to radiate. And so that'll get localized external beam radiation most of the time. A positive margin that cannot be resolved at frozen section, that almost all the time will get, unless there's a contraindication to radiotherapy, will get uh, external beam radiation. The sort of overarching exceptions to these would be if the tumor is truly a T4B and it's so advanced that it's up wrapping around the carotids, or if it's, or anytime you have major vascular involvement, it's very dangerous to do radiotherapy. Radiation tends to weaken blood vessels as a general rule, and so I've had two autopsy cases of post radiotherapy patients. One for a head and neck squam, and the other was for a pulmonary tumor, adenocarcinoma, but both of them got localized radiation. Unfortunately, managed to weaken major vessels in the neck, as well as one of the branches of the aorta in the latter case. And the patient just bleeds out. Usually, and not necessarily with exertion, just eventually the thing spontaneously ruptures. So, as a general rule, we try not to, if it's that advanced, that might eventually just send the patient to palliative care. It just depends um, on what the patient's thinking downstream.
Right. So generally, we want to avoid radiotherapy as much as possible, right? For those reasons that you mentioned, and it's very interesting for us to note as PAs that you define a close margin as under 3 millimeters. Um, if I was given the chance to define a close margin, I would say less than 1 centimeter. So it's good to know that it's these sort of very close measurements that we can't really tell grossly. That we need to sample and make sure that we give you a good section of, because you're really the one who can make the distinction between those millimeter differences. So, final question for me: How important is it to sample the uninvolved larynx, either as part of a tumor section or independently?
Yeah. So the uninvolved link, so again, depends on where the tumor is located, in part. For a supraglottic tumor, um, it is very nice to get a section of hyoid bone, even though most of the time the hyoid bone is not involved. If the hyoid bone is freely movable, then I suppose I don't really need a section, unless it appears to me that it's heading toward the direction of the hyoid somehow. But I'm not sure how I would tell that on the scope. Anyway, and epiglottis, half the time I don't get an epiglottic section. That's okay if it's a glottic or infraglottic tumor, but if it's supraglottic, I do sort of need an epiglottis section. Epiglottic sections in general are not always a bad thing. You find weird little things in the epiglottis that you wouldn't necessarily expect to find. Sometimes you'll find little cysts, or you might even find a little bit of early dysplasia. So a lot of places will routinely give you a midline just above the anterior commissure section of the epiglottis. I don't necessarily care one way or the other, unless it clearly is involved with the tumor, and I'm not going to go back and ask anyone to sample it. For glottic tumors, there's not really much more normal sections you can give. I don't really need anything above or below. Um, if anything looks odd, within the infraglottis outside of the tumor, then certainly sample it, especially along the mucosal, because you can sometimes get skip lesions, or you can get skip dysplasias that will sort of spread. And it's nice to know if that is something that's happening in this particular patient, if there's dysplasia that's maybe coming down toward the tracheal margin, then that implies that there could be further dysplasia beyond the tracheal margin. That's just not being sampled, and that makes this patient therefore high risk and should be monitored a little more frequently. Um, let's see, sections of trachea, and sometimes, and I think the ENTs here are a little more conservative than Other places I've been, other places I'll get 5, 6, 7 rings, maybe more, like a lot of trachea. Here I get maybe the examples I've seen have been maybe 2 or 3 rings of trachea so far. And so if I get a good section of that, it's certainly the tracheal margin you guys will take, but if I get a good section of random trachea, that's fine too. But if you don't see anything grossly, I'm happy to take your guys's, gross impression. I don't really need that sample. Um, oh, thyroids. Uh, so thyroids, gross. This is very important, and I say this because I do thyroids, and I am very much on the camp of not submitting entire thyroids. I don't agree with that's not how I do thyroids. However, um, gross them the same as you would a normal thyroid. And if you find something that looks suspicious, put that in as your representative section. It might mean that we go back later, or if you want to put 2 or 3 in, you can. Most of the time the thyroid comes along for a ride, and I just need to document that the tumor is not extending into the thyroid. But um, sometimes you get an incidental papillary thyroid carcinoma, and that's not an infrequent thing, and it's just how it is.
Great. So I think at this point we're going to open up the questions to the audience. So if you're able to read the chat, we do have
Yeah.
a couple. The first is from Emmanuel Chung. So thyroid involvement, is that considered local involvement?
So let's see. Thyroid involvement, is that considered local involvement? So it would be direct extension from the tumor into the thyroid gland proper, and that would it depends on the tumor, or the location of the tumor, but we would consider that to bump up to a I think T4 most of the time. I'm trying to remember the last time I had a tumor that was large enough to extend down into the thyroid, and sometimes I think we ended up bumping that up to T4A as memory serves, because the assumption is it's going through the level of the thyroid cartilage, even if it's not necessarily going through the thyroid cartilage. It could just be coming around it or down, and sometimes they'll um, escape inferiorly down around the thyroid cartilage into the thyroid gland. But I can still consider that local uh, invasion, and I would still upstage accordingly. I hope that answers that question.
That thyroid is listed on the CAP checklist as a T4A
Yeah,
um, criterion.
yeah, there it is.
Yeah. Question from Sarah Morgan: is paraepiglottic space the same as the piriform fossa?
Is paraepiglottic space the same as the piriform fossa? So the piriform so I tend not to use piriform fossa as a term myself. I use piriform sinus, and the piriform sinus is over here by the areoepiglottic fold. The paraepiglottic space comes a little further inferior, at least in that's how I've been characterizing it. It's a bit more inferior to the piriform sinus.
Question from Megan F. How about chondro type tumors? So I'm assuming cartilage forming or cartilage based tumors.
Yeah, so that's a great question, and this is not so it's slightly more common than you would think it is, because it's probably once a year, twice a year, out of these various cartilages that comprise the larynx, I'll get a tiny tumor that's either some kind of a benign chondroid tumor, or else it's a true chondrosarcoma. The largest series of chondrosarcomas of the larynx is by Lester Thompson, 72 cases, and that was almost 2 decades ago now. That in that series, most of these are localized to the larynx. They usually don't obstruct. They usually grow outward in the neck as opposed to inward, which is kind of unusual. The exception to that is if they arise out of a tracheal ring, which is extremely rare but does happen. When you are grossing these, you I would so my view is that they should be grossed as a normal larynx would be grossed, because you'll end up getting the same um, information that you need to if it ends up being a chondrosarcoma. If it's benign, then it's not going to matter. It's just a question of us documenting where is it in what structures is what structures is it involving and really justifying the surgery. So this larynx had to come out because the thing is going into the ventricle, therefore impairing mobile or vocal cord mobility. As a if it ends up being a chondrosarcoma, I there's no great consensus as to how we're supposed to stage those. Some I know that there are people who are using larynx criteria and the larynx synoptic for that. I use the sarcoma synoptic because it is a sarcoma, and even though it's arising in the larynx, I still use the sarcoma synoptic. And then I sort of modify the sarcoma synoptic to include elements of the larynx um, in a anatomy. So it almost at the end when I finally sign it, it ends up becoming a very long report with a um, almost hybrid view or form of the two synoptics. When it comes to sarcomas in this area, um, again, it's all about the gross. It really is. It's documenting where did it go and why did the larynx have to come out? Why did we have to stop this? Take this person's voice away. And then, as far as the actual sarcoma is concerned, it comes down to the microscopy as to how aggressive it's going to be. So you don't. I will say one less thing about this, less important thing about the if sarcoma is arising in this area, is really the T staging because the sarcoma T staging is much different than the larynx T staging. So even though it might be a T4 by laryngeal standards, it might only be a T1 or 2 by sarcoma standards. And in terms of, I will typically report all the elements that to where someone can infer what the T stage would be by a larynx standard, but I'll usually report the T stage as the sarcoma standard because at the end of the day, the sarcoma team is going to be who handles the case, and they're going to be the one, and the radonc is going to treat this according to sarcoma standards as opposed to larynx standards.
Right, so sort of a hybrid approach
Yes.
for these sort of cartilage forming tumors.
Yeah, usually about one. I think it's about once a year I get one of these randomly, and it's never expected. And half the time, or it's never expected on my end. The radiologist always seem to know what it is, but on my end, it's never expected. And then I have to sit there and figure out how to deal with it once a year. But it's surprising because you don't really think about benign cartilage tumors, and most of the time they are benign in this area. A chondrosarcoma of this area is extremely unlikely. But and when you think about benign cartilage tumors, this is not really the location where you think of them occurring, but they certainly do happen. There are, I will say, and when I have residents in the room, I usually try and present to them multiple schools of thought because I think that's one of my jobs is a lot of pathology is opinion. So a lot of pathology, I will tell you a lot of things, but some of that is opinion, some of it's actually based in like real papers in science, and some of it's just experience. One of the, one set of it, one relevant point to this is that there is a philosophy that there are no benign lesions, no benign cartilaginous lesions of the larynx. Instead, there are, if it's a cartilaginous lesion, it is automatically chondrosarcoma. I don't know how true that is or whether it's provable one way or the other. I will say I have seen tiny little 1 centimeter chondroid lesions that are just, inchondromas that are just sitting there next to the hyoid bone or arising out of the thyroid cartilage that we're never going to never going to do anything. They were never going to kill the patients, but they came out because they were obstructing the airway. Maybe they just happened to impinge enough to where it needed to come out. That type of a scenario.
Right. So, different schools of thought. Always good to teach our students multiple different ways of approaching the same problem. Um, and until more data comes out, a lot of these approaches could be equally valid.
Yep.
Okay. All right. So, one final point for Sarah Morgan, who is still confused by relation of cricoid to thyroid cartilage. So, the cricoid cartilage is just inferior to the thyroid cartilage, and it also forms a complete ring, unlike the thyroid cartilage, which is an incomplete ring. And the thyroid cartilage will also have superior and inferior horns, and those will probably be very palpable. It's easy to confuse the superior horns of the thyroid cartilage with the hyoid bone, and that's just how prominent they are. And if you were to bisect your specimen and just follow the thyroid cartilage around, you would be able to see its distinction from the cricoid cartilage. But with that, I think that does it for our session today. I think we're out of time. So thank you so much, Dr. Smith, for joining
No problem.
us.
Yep.
And if you could all fill out a feedback form, the link is in the description. We'd love to do this again, but only if you guys enjoyed it. So thanks again for watching, and hopefully we'll see you again.
Yes.